Good afternoon, everyone. It's my pleasure to be the final speaker of the day. Yes. So my name is Karen Fancher. I'm an associate professor of pharmacy practice at Duquesne University in Pittsburgh, Pennsylvania, and I also have a practice site at the University of Pittsburgh. Go Steelers. Yes. Thank you. So it is my privilege to be here today. It is such an honor to get this opportunity every year. This is my 11th time giving this talk, and ASHP and ACCP keep asking me back. Despite the fact that I make corny jokes and I'm very sarcastic and things, they keep asking me. And if you've heard this before, you might know where I'm going with it, and we'll see if I do the same thing, if anybody's heard me give this lecture in the past. So today we're going to cover the chronic leukemias. These are my financial relationships. Here's the learning objectives. And in the handout, we have information about infusion-related reactions from monoclonal antibodies and hairy cell leukemia that we won't get to cover in this discussion. So I have the task of covering the chronic leukemias, which are actually two very different disease states, so CLL and CML. So we're going to split them up, and we'll do CLL first, or chronic lymphocytic leukemia. So for those of you who don't love the heme-onc world, as a reminder, CLL is an accumulation of small lymphocytes, or B cells, in numerous tissues, so blood, lymph nodes, spleen, and bone marrow. There actually is a separate type called SLL, so small lymphocytic lymphoma, but for our purposes, that's the same as CLL. The tissues they distribute into are slightly different, but we treat them the same, so from here on out, we're just gonna go with CLL. Typically, this is an indolent disease, and survival can range anywhere between 1 and 20 years. So you may not need to initiate therapy right away, depending on certain patient characteristics. Likewise, many patients will live with CLL but die from another cause. So our choice of therapy needs to be very thoughtful. And that leads me into the last bullet point here, that we are talking about a very elderly patient population. So our average age is somewhere in the low 70s. So again, we have to think very carefully about comorbid conditions and what is our patient's goals given their age. So historically, we would classify patients with CLL based on two staging systems. One's called the Rye and one's called the Binet. These are only for historical purposes in 2024. So you can see here, Rye stage 0 or Binet stage A would be very early stage where we may consider active surveillance. I do have some information in your handout about when you would intervene, like which patients are appropriate to do active surveillance and which do not or are not. So please check that out in the handout. And then moving through the stages, you can see some of the patients may benefit from therapy all the way up to symptomatic patients who need immediate intervention. But again, this is historical purposes. You would never be asked to calculate a patient's Rye or Binet score. And even if it was provided to you, it's probably not the way you would make your decisions. So in 2024, we would look at some genetic mutations and some other markers to help us decide between therapies. So the first thing we would look at is what's called your IGHV region. So on the outside of B cells, you have those Y-shaped immunoglobulins, and if those are mutated, that's actually a good prognostic marker. So this is one of the situations where you want to see the mutation. And again, they'll give you a percentage as to how many cells have that mutation or what percentage of the cells are mutated. And again, anything more than 2%, I'm happy to see. I want to see this IGHV mutation. Okay, why is that? If the cells have already mutated, it shows you that clonal evolution has already occurred. Okay, the disease is what it will be. It's not going to change over time. If it's unmutated, it's more likely to change as we move throughout therapy, so those patients are a little more difficult to estimate what's going to happen, if that makes sense. We can also look at several chromosomal abnormalities. The one that you should see as a giant red flag is called deletion 17p. All right, there are others, but this is the only one that we would use to make treatment decisions, again, in 2024. The deletion 17p mutation is associated with a loss of the tumor suppressor gene, TP53, which we all know is critical in DNA repair. So patients that are deletion 17p are typically very symptomatic. They're resistant to traditional chemoimmunotherapy, and they're the ones that have the shortest survival. So again, that's the one that should jump out at you. So this is a summary table that I made. Again, which cytogenetic abnormalities are not good. The one that you should star here is deletion 17p. It is favorable to have that IGHV mutation. That's a good thing. We can also measure several tumor markers, so CD38 and CD49. I have some examples here. You may see these in the studies, but we do not make treatment decisions on any of those right now. And likewise, TP53 mutation is always bad in any cancer, but also true in CLL. So we would take all of that information in addition to the individual patient. Okay, so we need to take a real good look at that patient's fitness for therapy. Dr. Parasanati already mentioned today that sometimes we have a 70-year-old that still runs marathons, and we have a 70-year-old that is wheelchair-bound and on oxygen, right? So the number, their chronologic age, is not the way we decide. We decide based on their physiologic age. How do we assess that? That's the million-dollar question, right? There's many scales to assess performance status, Sears and Karnofsky and all of those, but none of those are specific to cancer patients, and none of them are specific to CLL. Okay, so it's a judgment call about a patient's fitness for therapy. But things that I would consider would be their other comorbid conditions, and I need to see their med list, because most CLL patients take at least 5 other medications that may interact with some of the drugs I will show you later. So I've been doing this lecture since 2014, and I feel like I've seen the whole gamut of how we decide things for patients. But in 2022, the NCCN took away the age category. So if you've ever looked at it before now, it would say less than 65 or greater than 65. All of those numbers are gone, and all of our treatment decisions are now made based on that deletion 17p and IGHV mutation status. So that brings us to our first patient case. We have a retired 68-year-old male with a history of chronic kidney disease, hypertension, and hypercholesterolemia. He noted significant lymph node swelling in his neck about 6 months ago, which did not resolve with antibiotics. So he returned to his family doctor, where his CBC revealed marked lymphocytosis, and eventually flow cytometry confirmed the diagnosis of CLL. After further workup, he was classified as Binet stage B, and his cytogenetic analysis shows us that he has deletion 13q and unmutated IGHV. He's considered medically fit to receive treatment, and he is interested in a regimen that can be completed in a short amount of time. So, given this information, which of the following treatment regimens is the most appropriate first-line choice for this patient? I'll open the poll here. Your choices are A, acalabrutinib, B, chlorambucil and ofatumumab, C, fludarabine, cyclophosphamide, and rituximab, or D, venetoclax and obinutuzumab. Oh, I think I did that too early. All right. So you guys are like on fire already. Everybody wants to get out of here. All right. So I would argue that the most appropriate answer of the choices that I gave you is actually D, venetoclax and obinutuzumab. All right. So it would be appropriate to initiate a patient in the first-line setting on a Bruton's tyrosine kinase inhibitor, on acalabrutinib. However, that is indefinite therapy, and this patient specifically said he wanted a short interval. You may be attracted to FCR, but this patient has unmutated IGHV, and that is one of the exceptions for that regimen. All right, so of the choices, venetoclax and obinutuzumab, 1 year of therapy, and it's a category 1 recommendation, so that's what I would go with. All right, so again, I've been doing this since 2014, you guys, and I feel like I'm sending a child off to college here on this slide. So in 2014, I distinctly recall standing in Washington, D.C. and saying, you know, we think this ibrutinib is going to be something big. All right, yeah, it was. And now it's actually on the way out. We are doing so much better than ibrutinib that it's actually having like its own sunset. So, you know, yay for progress, right? All right, so this is now first-line therapy, patients without deletion 17p or the T53 mutation. Preferred regimens include the Bruton's tyrosine kinase inhibitors, acalabrutinib, either alone or in combination with obinutuzumab, the anti-CD20 monoclonal antibody, or zanubrutinib. We could use the BCL2 inhibitor, venetoclax, in combination with obinutuzumab. So all three of those would be very appropriate first-line choices. Ibrutinib's been given a very unique designation here. It's a category 1 other recommendation, but not preferred. All right. Again, we'll talk about why, but mostly because of adverse effects. In certain circumstances, we could consider the old chemoimmunotherapy regimen called FCR. This would be for a patient who is IGHV mutated, very young, and very healthy. All right, so to briefly review some of the studies that got us here. First, looking at acalabrutinib, this was studied in the first-line setting in a study called Elevate-TN, or treatment naive. This was a large number of patients with previously untreated CLL. Then I would consider this an older patient population. They were over 65 or less than 65, but had comorbid conditions. They were randomized to what was the standard of care at that time. So acalabrutinib alone, acalabrutinib plus obinutuzumab, or chlorambucil and obinutuzumab, which we now know is not a preferred regimen, but that's what was appropriate at that time. And the primary endpoint was progression-free survival. All right, so briefly summarizing the results here, no big surprise, both of the acalabrutinib-containing arms outperformed chlorambucil and obinutuzumab. However, there was not a big difference between acalabrutinib alone and acalabrutinib plus obinutuzumab, so for those reasons, the guidelines suggest either monotherapy or in combination with obinutuzumab. And you can see here, these are great numbers, overall survival at 60 months. Again, patients do quite well and can go quite a long time with any treatment, given the indolent nature of CLL. Our next regimen, venetoclax and obinutuzumab, was compared to, again, chlorambucil and obinutuzumab in previously untreated patients who had comorbid conditions in a study called CLL-14. So again, no surprise here. Venetoclax and obinutuzumab clearly outperformed the chlorambucil arm. But things that I want to call to your attention here, the time to next treatment, so when the patients had to choose another therapy, was significantly longer in the venetoclax arm. But both arms needed quite a bit of growth factor. So the trade-off of that 1 year of therapy might be a greater incidence of myelosuppression. So this slide just has the conclusions of everything I said. The 72-month progression-free survival and time to next treatment was better with venetoclax and obinutuzumab. That was in all comers, so TP53, unmutated IGHV. Both arms needed quite a bit of growth factor support. But again, a serious advantage here is that this is 1 year of therapy. So the lingo we use is either fixed duration or time-dependent therapy. Very recently, the Gaia CLL-13 study was published right before Christmas. So this was a very large study of almost 1,000 patients with previously untreated CLL, and they were randomized to one of 4 arms. So the historical standard of FCR or BR, bendamustine and rituximab, venetoclax and rituximab, venetoclax and obinutuzumab, or now getting completely crazy, triple therapy, venetoclax, obinutuzumab, and ibrutinib. The trial had 4 arms and 2 primary endpoints. So I want you all to thank me for not picking this article for those home study syllabuses, because this would have been a nightmare, right? The 2 endpoints were progression-free survival and what's called undetectable minimal residual disease. So as you heard from Dr. Parasanati earlier in the ALL lecture, we may be interested in minimal or measurable residual disease. We are not there yet in CLL, so this was a very novel endpoint. I have more information in the handout, but for testing purposes, I don't think that's going to be a question. All right, so of this 4-arm study, venetoclax and obinutuzumab and the triplet therapy were easily better than FCR or BR. Okay. Venetoclax and rituximab was not any better than FCR or BR. So of this chart here, the first 2 columns are clearly better, all right, in terms of progression-free survival. Between those 2 arms, the triplet therapy had a higher incidence of infection. So this has not yet become the standard of care. Who knows what I'll say next year, folks? But right now, this study kind of cements the place of venetoclax and obinutuzumab in the first-line setting. Looking at zanubrutinib in the frontline setting, the Sequoia study is a large study of many different subtypes. This is actually still ongoing, but the cohort 1 arm compared zanubrutinib to, again, what was the standard of care at the time, bendamustine and rituximab, in treatment-naive patients. No surprise, zanubrutinib had better PFS, and it was actually superior in some of our high-risk subgroups. However, it did not include 17p. But again, clearly this is a preferred agent based on the response rates. And just to be fair, I put in a slide about the ibrutinib approval study in the frontline setting. It was called Resonate-2. And again, how long ago was this? It was ibrutinib versus chlorambucil alone. Again, the results were not surprising. Progression-free survival and overall survival clearly favored the ibrutinib arm, even at 7 and 5 years out. But what was also very groundbreaking at that time was that patients' other blood elements actually recovered by giving ibrutinib, so the patients needed less transfusions of blood and platelets. So ibrutinib is still in the guidelines, as I mentioned, as a category 1 other regimen in the frontline setting. Okay. There are other trials of ibrutinib in the frontline setting that are detailed in your handout, but not here in the slides. Those studies actually investigated ibrutinib in combination with rituximab or other agents. But right now, ibrutinib alone is the category 1 other recommended regimen. It's not clear that adding an anti-CD20 monoclonal antibody to ibrutinib in the frontline setting gets you any benefit. And as I have been hinting at, we're seeing some cardiac toxicity that we don't observe with the other agents that is making this one fall out of favor. All right, so where does FCR fit in? We did say that is appropriate for a very small niche of patients. So CLL-10 studied FCR, so fludarabine, cyclophosphamide, and rituximab, against bendamustine and rituximab in previously untreated, medically fit patients with CLL. A lot of data on this slide, but what I want to call your attention to is in all comers, the progression-free survival benefit or favored FCR. So that sounded good. But when we did the subgroup analysis, elderly patients, so greater than 65 years of age, did not have that progression-free survival benefit. So the subgroup analysis has shown us that younger patients are the ones driving that full group benefit. So for that reason, we are attracted to FCR in a patient under the age of 65. We are also attracted to FCR in younger patients because of the difficulties in terms of adverse effects. So the bottom 2 rows here, more neutropenia, more infections. I didn't include it here, but questionable more secondary malignancies. So as of this moment, we use FCR in mutated IGHV, who are under 65 and do not have significant comorbidities. It's not on the slide, but I will mention, you guys, FCR is 6 months of therapy. So a patient who is very interested in the shortest amount of time and meets all those other criteria might be interested in FCR. All right, so what about patients with deletion 17p? It's exactly the same thing that I just showed you, just not as strong of recommendations. So preferred regimens, acalabrutinib plus or minus obinutuzumab, venetoclax and obinutuzumab, or zanubrutinib alone. Other recommended regimens, ibrutinib. However, as I mentioned at the beginning, patients with deletion 17p do not respond to chemoimmunotherapy. So you would not select FCR for a patient with deletion 17p, regardless of their age or IGHV status or any of that. This is the one time that FCR would be very wrong. All right, so CLL, as much as I love it, is not curable. So patients will universally relapse and need more therapy if they live long enough and are fit enough to receive a second regimen. So let's think about what we would do then. We have a 63-year-old male with CLL with deletion 11q, well-controlled AFib, and gastroesophageal reflux disease. He got FCR 3 years ago and has had a complete response, but has recently relapsed. So which of the following regimens is most appropriate for this patient at this point? Would you repeat FCR, chlorambucil and obinutuzumab, zanubrutinib, or bendamustine, rituximab, and idelalisib? So there's the poll. All right, I'm going to close this. Very good, very good. Again, of the options that I presented to you here, I would argue that zanubrutinib is the most appropriate. I tried to trick you a little bit. I said AFib, right? But I said the magic words, well controlled, right? Likewise, triplet therapy with bendamustine, rituximab, idelalisib. We have tried that and it is not good, so no. Chlorambucil and obinutuzumab, not preferred. And again, there was a time where we would have repeated FCR. If anybody's old school about that, talk to me later. But we would not do that in 2024. All right, so of these, yes, zanubrutinib, excellent. All right, so as I mentioned, even with all these wonderful novel agents, CLL is incurable and everyone will relapse sooner or later. What we do at that time depends on their age and their performance status, what they've had in the past, how well they did on that initial agent, and if they've been off therapy for a while, how long have they been off that therapy? So this slide is a summary of second and third line choices for patients without deletion 17p. Preferred regimens are still going to be our BTKIs, acalabrutinib and zanubrutinib. Also venetoclax, but in the second line setting, it's been studied with rituximab instead of obinutuzumab. Under other, category 1, there's ibrutinib again. In certain circumstances, you could consider retreating the patient with venetoclax and obinutuzumab. That's the 1-year regimen, if you recall. It says for relapse after a period of remission. It doesn't say a specific time period. So period of remission is open for interpretation. But I would argue if it's been a good long while and the patient is agreeable, that may be a reasonable option. And we have a new BTKI called pirtobrutinib, which is now only indicated for resistance or intolerance to a prior BTKI. So we'd have to try one of those first, but we now have a fourth BTKI in this class. All right, so to briefly summarize this data, acalabrutinib was studied in the relapse and refractory setting versus investigator's choice, which at the time was idelalisib and rituximab, or bendamustine and rituximab. Primary endpoint of progression-free survival, highly in favor of acalabrutinib in all subgroups. They did mention there was not a difference in overall survival, but the study actually allowed crossover, which you can imagine most of the patients in the other two arms wanted to do at some point. So again, acalabrutinib is a rational choice in this setting. Looking at venetoclax, the study in the relapse and refractory setting is called Murano, and that was venetoclax plus rituximab. This regimen takes 2 years, so as opposed to the 1 year of venetoclax and obinutuzumab, this is a 2-year regimen, but still time-dependent or still fixed duration for a patient who is interested in that. Again, the results were highly in favor of the venetoclax and rituximab arm. Notice at the bottom there, this study, even though it was done quite a while ago, was the beginnings of that undetectable MRD, which again was in favor of venetoclax and rituximab, but we do not use that for treatment selection as of yet. Looking at zanubrutinib in this setting, the Alpine study compared zanubrutinib to ibrutinib in patients who had never received a BTKI in the past, so that kind of implies they received FCR or some other regimen. And zanubrutinib was actually superior in this case with respect to progression-free survival. So once again, waving goodbye to our old friend ibrutinib. But for fairness, as I said, they're like all of my children, you guys. I have to be fair to them all. Ibrutinib, way back in the day, was originally studied in the relapse and refractory setting against ofatumumab, which we don't use ever anymore, which was in the original Resonate trial. And again, there's no question of its benefit in the setting at the time. However, given our concerns about adverse effects, this is now a Category 1 other recommended regimen in relapse and refractory disease. All right, so moving to our newest BTKI, pirtobrutinib, is currently indicated in mantle cell lymphoma and relapse and refractory CLL. So I'm going to talk about mantle cell lymphoma tomorrow. We will talk more about dosing and adverse effects and those kinds of things. But for today, we can talk that it is a non-covalent BTKI, with the other ones all being covalent, so a difference there. This has reversible binding, and it may overcome some of the resistance from a very specific mutation that we can see with prolonged BTKI therapy. So pirtobrutinib has been studied in a wide variety of B-cell malignancies in a study called Bruin that has multiple arms. I pulled out the CLL data for you here. So these were patients who had received a previous BTKI in the majority of patients, and pretty impressive overall response rates there. And you can see here, this was in the second or third line setting for many of these patients and had a progression-free survival of 18 months or more, which again was great news when we get to this point of therapy. All right, so now thinking about second line and subsequent therapy in patients with a deletion 17p mutation, it's everything I just said. Those two slides are exactly the same. So once you get to the relapsed and refractory setting, we treat them the same regardless of deletion 17p status. So what do you do for a patient who needs third-line therapy, someone who has received both a BTKI and venetoclax? All right, so these patients, we can classify them different ways, but they're usually called double relapsed or double intolerant, right? So if they've never tried pirtobrutinib, we could actually consider that here, given it's a different mechanism and works in a different binding. We could pull some stuff out of the closet here and use PI3K inhibitors, duvelisib and idelalisib. Again, you guys, these were all the rage before the BTKIs, but they have now been demoted to the third line setting. And because I have to mention that the NCCN guidelines mention the use of chemoimmunotherapy or immunotherapy alone in this setting. In my personal experience, these are elderly patients that have a ton of comorbid conditions. There is no way we're getting FCR into these patients, but I'm obligated to say it's in the guidelines. All right. So I've shown you a lot of different options. So now let's talk about how we would distinguish which one is better for our individual patient. All right, let's talk about side effects. So we have a patient who will be receiving venetoclax and obinutuzumab for his newly diagnosed CLL. Which of the following statements about venetoclax is correct? Is it A, pancreatitis is common? B, tumor lysis syndrome prophylaxis is required? C, lower extremity edema often occurs? Or D, visual changes are frequent? I feel like you guys are just over it right now, like nobody's even voting. So thank you for hanging in there with me, those of you that are voting. All right, excellent. So venetoclax is associated with tumor lysis syndrome, which we will talk about is unusual for a chronic cancer, but that is its hallmark side effect. Pancreatitis and lower extremity edema, I actually pulled those from the CML drugs, which we're going to talk about momentarily. I thought I might confuse you there. Visual changes I just made up. All right, second question. 71-year-old female with newly diagnosed CLL who will be initiating therapy with acalabrutinib. Which of the following adverse effects are frequently seen with that agent? Is it hypotension, tumor lysis syndrome, headache, or periorbital edema? All right, I'm going to close the poll here. Excellent. You guys are CLL experts already. Very nice. All right, so the hallmark or the standout adverse effect of acalabrutinib is actually headache. Hypotension, we don't see very often. We see actually the reverse, hypertension in some of these agents. Tumor lysis syndrome was venetoclax. And periorbital edema is from imatinib in the CML data I will show you in a little while. Great work there, very nice work. All right, so talking about adverse effects now, leading off with what I've been hinting at the whole time. So we have cardiac toxicity concerns about ibrutinib after our extensive experience in tens of thousands or hundreds of thousands of patients. The two main cardiac events that we see are AFib and hypertension. So AFib somewhere between 7 and 10%. Even in patients who have never had AFib before. Hypertension higher than that, and usually very fast. First 6 months or so, there is no preferred agent. All right, so to treat the hypertension. So given that we have an elderly patient population that often has AFib or is at risk for it, and then the management of AFib is going to complicate things in terms of bleeding or drug interactions. So again, we're kind of seeing the sunset of ibrutinib here. The recommendations are any patient starting a covalent BTKI should receive a baseline cardiac evaluation. I have it on the ibrutinib slide, but it's true for all of them. However, what if you have a patient who's been stable on ibrutinib for 7 years and it doesn't have any issues? You don't have to change them. Okay, this is not a warrant. Does not warrant a change as long as everything else is stable. And if the patient agrees. But the presence of AFib doesn't warrant a change. All right, other adverse effects we see with ibrutinib, we see bleeding events, which is hard to quantify. It's serious in about 5% of patients. So clinical pearls here, you would hold ibrutinib for either 3 or 7 days if the patient needs a surgical procedure, depending on the severity of that procedure. The approval trials excluded patients who were on warfarin, But there's some great data these days for DOACs in patients on BTKIs, so that is a relief. And again, the official lingo is to consider non-warfarin anticoagulation, but I'm very comfortable recommending a DOAC with some of the data that we have. We also see some annoying but very bothersome side effects to patients, so arthralgias, transient diarrhea, and again, drug interactions are going to be problematic, especially if we need to add drugs for AFib. For acalabrutinib, number one adverse effect is headache. We see this in about half of patients. The good news is it is very self-limiting, a month or two, and typically resolves with fluids and, my favorite, caffeine. So I refer the patients to our hospital Starbucks to treat their headache. Right? We see less bleeding, hypertension, AFib. Notice it's not zero, I said less with these patients. And if anybody is into the actual drug acquisition or dispensing of the drug, the formulation has recently changed. Okay, historically, acalabrutinib was available in capsule formulation, which interacted with both H2 receptor antagonists and antacids, which we know nobody in this country takes, right? The company finally realized that wasn't a good idea and very recently introduced the tablet formulation, which does not have these interactions. The capsule formulation is being phased out. But again, given the timing of the exam, I think that might be a fair question, so be aware of that. All right. Now, there was a trial recently called Elevate-RR, so Elevate Relapsed Refractory, whose primary endpoint was actually to compare ibrutinib and acalabrutinib for efficacy. Okay, this was a non-inferiority trial and showed acalabrutinib was non-inferior to ibrutinib in terms of efficacy. But what made this trial noteworthy was their key secondary endpoint, which had to do with those cardiac effects. So this trial basically showed us what we already knew. Acalabrutinib has less AFib, less grade 3 infections, less bleeding. All of the side effects still occur, but at a much lower rate. So we're confident now, again, that ibrutinib's kind of the bad guy here. Zanubrutinib, its hallmark side effects usually have to do with blood counts, so myelosuppression and such. I will mention in the next slide or two what transient lymphocytosis is. Again, we see cardiac effects like hypertension and AFib, but less than ibrutinib. But what I want to call out here is that zanubrutinib is the newest of the covalent BTKIs, so we have the least amount of follow-up data to see if these the percentages. This is a chart I made comparing all the BTKIs and their hallmark side effects. So you can see there's a lot of red for ibrutinib, here and there for acalabrutinib and zanubrutinib. Pirtobrutinib appears to be well tolerated, but again, the data is very, very short follow-up, so it's hard to say. Thinking about venetoclax now in terms of adverse reactions, you all, or most of you, got tumor lysis syndrome as its hallmark side effect. Again, when this agent was first introduced, this was a surprise. Tumor lysis syndrome was a surprise. You do not typically expect that with a chronic cancer. However, the inhibition of the pathway that venetoclax works on was so powerful that the cells spontaneously died, or quickly died. So in the phase 1 studies, patients actually passed away from tumor lysis syndrome. We are well aware of that now, so we do several things. We do what's called ramp up the dose, and that is actually the terminology that's even used in the prescribing information, ramp up. There is a table in your handout that shows you other interventions to prevent tumor lysis syndrome, fluids, allopurinol, rasburicase, and what have you. And again, for more information on tumor lysis syndrome, I refer you to Dr. Parasinati's handout. Going way back now to the PI3K inhibitors, idelalisib and duvelisib, these have fallen out of favor for both efficacy and safety reasons. So my friends, I am a former bone marrow transplant pharmacist. I'm in my 14th year of recovery from that. And when I think about these drugs, I start jonesing for GVH. Seriously. All right, the side effects to idelalisib and duvelisib look a lot like GVH in terms of liver toxicity and the colitis that these patients get. So they are very difficult to tolerate. As you can see here, there's some concerns about opportunistic infections. I can't think of the last patient we started one of these agents on, but I think it's a fair question how you would manage those toxicities. So there's some more information in your handout. All right, I mentioned on several of the slides that these agents are associated with lymphocytosis. All right, so what does that mean? So it's actually a really cool phenomenon that pharmacists can play a very important role in explaining to patients. So when we start a BTKI or venetoclax, the lymphocytes are actually mobilized out of the lymph nodes into the peripheral blood where they die. So if you had a patient who was very vigilant at looking at their own labs, they're actually going to see their lymphocyte count increase in the first couple weeks. So if you were a patient, what would you think? My drug is failing, right? And these are all oral drugs that the patients are taking at home alone. So it's very important to stress that we expect this to happen, and it's actually a good thing. The drugs are doing exactly what we wanted to do. Move those cells out to your peripheral blood where they will die. So this is not an indication of treatment failure. It's actually an indication of treatment efficacy. And again, it usually resolves itself in the first two to 3 months. All right, so in summary, I prepared this for everybody to study from. So patients without deletion 17p, preferred regimens, acalabrutinib with or without obinutuzumab, venetoclax and obinutuzumab, or zanubrutinib, all category 1. On the right-hand side, ibrutinib, category 1, maybe. In certain circumstances, FCR, but only for patients who are mutated IGHV, young, and fit. Second or third line therapy would depend on what they had in the first line setting. Again, we can use BTKIs or venetoclax in combination with rituximab. For a patient who has received venetoclax and obinutuzumab and had a long remission, you could consider repeating that. And if the patient was resistant or intolerant to other BTKIs, you could consider our new agent, pirtobrutinib. Is anybody a fan of The Mandalorian? This is the way. All right, I also made this slide of how I think about this in my head when we're choosing patient therapy. A patient may prefer venetoclax if they want that time-limited therapy, if they have a high risk of bleeding because I don't have to worry about drug interactions with warfarin. If they absolutely need warfarin for a valve replacement or whatever, venetoclax would probably be preferred. Less cardiac effects with venetoclax. And I have financial concerns, question mark, because we know that's always a wild card, right, of how much drugs will cost over time. On the flip side, patients may prefer a BTKI if they absolutely cannot receive IV therapy for transportation issues, because venetoclax is always given in combination with a CD20 monoclonal antibody. If the patient doesn't mind that this will be lifelong therapy, and if they're at risk for tumor lysis syndrome, I would actually err on the side of the BTKI. In the third line setting, so someone who's tried both BTKIs and venetoclax, again, we could try pirtobrutinib. We could take a chance and use those PI3K inhibitors. And apparently some patients might actually get chemoimmunotherapy, but I feel like those patients are unicorns, right? Like, I think they're out there, but I've never seen one, right? So, all right, and for patients with deletion 17p, very similar to what we said, just there would be no FCR option here. Okay, so now thinking about some supportive care issues. We have a 63-year-old male who's been taking zanubrutinib for the past 18 months. And over the past 2 weeks, he has noted rapidly enlarging cervical, axillary, and inguinal lymph nodes. And he reports new fevers, splenomegaly, and unintentional weight loss. So which of the following is the most likely cause of his new complaints? Is it A, Richter's transformation, B, zanubrutinib delayed hypersensitivity reaction, C, redistribution lymphocytosis, or D, tuberculosis infection. All right, I will close this one. Very good. How many of you were tipped off by the very next slide? It's titled Richter's Transformation. I realized that as I was reviewing the slides. I will change that for next year. Yes, this patient is very likely having what we call Richter's Transformation. All right, that lymphocytosis usually occurs very early in therapy, so 18 months in this patient would not be common. And again, tuberculosis is not a common infection in patients on these agents. So very likely Richter's transformation. There is no delayed hypersensitivity reaction either. I made that up. All right, so Richter's transformation is when we have CLL that converts into either a diffuse large B-cell lymphoma or, in rare cases, a classical Hodgkin's disease. This occurs between 2 and 10% of patients, and every year that they have CLL, that incidence goes up slightly. So the longer the patient has their CLL, the more likely this is to occur. Unfortunately, when this happens, the patient's new lymphoma is usually very angry and very drug resistant. So these patients universally do very poorly. We would advocate that you start the appropriate therapy for whatever lymphoma they have as soon as possible, and you actually leave them on their therapy as a bridge until you can get to that new chemotherapy regimen, all right, which I will tell you about tomorrow, diffuse large B-cell lymphoma and Hodgkin's. All right, now we have a 71-year-old female with newly diagnosed CLL. She has no drug allergies and will be initiating therapy with acalabrutinib. Which of the following supportive care interventions is most appropriate for her to prevent complications from either the CLL or the treatment regimen? Is it A, the zoster vaccine recombinant adjuvanted, dapsone, valganciclovir, or IVIG? Oh, I feel like I stumped you on this one. There's a slow response this time. Let's see how it went. Oh, I got you guys. All right. All right. So the most appropriate answer here is actually the zoster vaccine. All right. We will talk about there may be some indications for PJP prophylaxis, but not with the BTKIs. Likewise, there's no CMV prophylaxis with the BTKIs. And shout out to you guys who picked IVIG. I feel like you're old school, thank you. But we don't do that currently. All right, so infections are a common complication in patients with CLL because they have a B cell problem, and then our therapy is directed at the function of B cells. We can correlate the amount of infections the patients get with their immunoglobulin levels. However, we don't routinely replace those immunoglobulins with IVIG. All right, the agents we would think about initiating prophylaxis are listed for you here. But again, these are the drugs that are a little more toxic and have fallen out of favor. So we don't always initiate anti-infective therapy with BTKIs or venetoclax. Again, IVIG may decrease the incidence of infections, but it doesn't change the patient's outcome. It's expensive and very hard to obtain at times. So the indications for IVIG in a patient with CLL would be a serum IgG level, you can actually check those, of less than 500, and recurrent sinus or lung infections that required antibiotics or hospitalization. Okay, so a very, very small portion of our patients will actually meet those criteria. Our patients, again, they're elderly, they're at risk for shingles and other reactivations, so we would consider acyclovir or some equivalent drug for herpes and zoster prophylaxis. However, we do not routinely do CMV prophylaxis. We could argue all day about what is the appropriate way to manage these patients, but most institutions would do antigen surveillance of CMV levels and intervene with valganciclovir or IV ganciclovir when those levels rise. We could consider PJP prophylaxis with sulfamethoxazole and trimethylprim or an equivalent drug if they're allergic, but only for the indications that we have here, which again are not the popular choices in 2024. And if our patient is going to receive treatment, especially with an anti-CD20 monoclonal antibody, we would want to do hepatitis B testing, which is detailed very nicely in the cancer-related ID handout. I want to give a shout out to vaccines in the CLL patient population. We would always advocate for an annual flu shot, the COVID vaccines that are available at the time, pneumococcus, zoster, but avoid all live vaccines. So the patient who is taking their bucket list trip somewhere that requires a yellow fever vaccine, we do not advocate for that. But otherwise, all of these would be indicated, even if the patient doesn't mount a full immune response against it. We would feel the benefit outweighs the risk. Okay, great job on that, everybody. So now we're going to switch over to CML, or chronic myeloid leukemia, which is my favorite cancer of all, everybody. I'm so lucky that ASHP and ACCP lets me talk about my favorite cancer, and for a couple reasons, right? I love cancers that have a happy ending, which I feel like a lot of these patients have. But I also love science, and CML was the first time we ever found a mutation and designed a drug specifically against it. And that always makes me excited for pharmacy, right? Like we did something good. So let's remind ourselves here that CML is a myeloproliferative disorder of your primitive hematopoietic progenitor cells. And this is because of a very specific chromosomal change. So there's a translocation between chromosomes 9 and 22. So if you've ever seen the pictures, the arms of 9 and 22 chromosomes actually change length because of the change in the configuration. And that genetic change, again called the Philadelphia chromosome because it was discovered in Philadelphia, results in the production of an oncogene called BCR-ABL. And that BCR-ABL produces an enzyme, tyrosine kinase, that is always on, is always telling those cells to keep going, do bad things, misbehave. Historically, there are 3 phases of CML. So chronic phase, where the only cytogenetic abnormality is that Philadelphia chromosome, and the patients are usually asymptomatic. Accelerated phase, where we start to see more chromosomal abnormalities and more symptoms. And eventually, if the patients are untreated, they'll convert into what's called a blast phase, where they look like an acute leukemic. Okay, we don't see those very often in 2024, but it's still in the literature. The newest term for that is actually advanced phase. So accelerated phase and blast phase kind of merged into something called advanced phase. So what are your goals here? You want to keep that patient in chronic phase for as long as possible. Okay, that's your number one goal. And prevent them from progressing into an advanced phase, like accelerated phase or blast phase. Some patients are going to be on therapy for decades, so I would like to minimize the toxicity of whatever I have chosen. And maybe I'm going to be able to get these patients off of that therapy at some point. We would call that TFR, or treatment-free remission. We can't achieve that in everybody yet, so I put question marks there, right? But once again, this is definitely showing some progress. These are great problems to have, you guys. How long can I stay on this therapy? Maybe not forever. For the rare patient who is in accelerated phase or a blast crisis, your singular goal is to get them back into chronic phase. Just beat their disease back down into that chronic phase, and then typically a transplant after that. All right, so CML has its own unique response criteria. So I have them listed for you here, but it's a 3-step process. The most basic response would be called hematologic response, where the blood counts return to normal. But in that case, you're not looking at cytogenetics, so that's really just treating yourself, right? That's just changing somebody's lab values. The standard of care is what's called a cytogenetic response, and the one we're aiming for in most of the older studies that I will show you is called complete cytogenetic response, or CCYR. So when we look at your chromosomes, none of them have that Philadelphia chromosome, 0. The Holy Grail is becoming what's called molecular response. So when we look at the individual genes, we cannot detect that BCR-ABL fusion oncogene anymore. So you can see here the major molecular response would be talking about log reductions and such. That is what we're aiming for in most of our newer studies here, is to actually make that gene disappear. Good stuff. All right, so our first patient case, we have a 65-year-old female with a history of COPD, psoriasis, and seasonal allergies. She presented for a physical as required by her new insurance plan. And there was a surprise. The blood work revealed a white blood cell count of 94,000, but hemoglobin and platelets in the normal range. So she eventually underwent a bone marrow biopsy, which was markedly hypercellular. Cytogenetic analysis was positive for the Philadelphia chromosome, which confirms that she has CML, and she is still in chronic phase. Her UTOS long-term survival score, or ELTS score, reveals that she has intermediate risk disease. So given that information, which of the following would you choose for this patient? Would it be imatinib, bosutinib, ponatinib, or dasatinib? All right, I will close the poll here. Interesting. Okay. So I could hear you guys like cursing at me in your own head. Like, what? Aren't those all right? Okay, there's some subtle differences here. So I would actually argue that of the choices that I gave you, the most appropriate choice for this patient is actually bosutinib. Oh, okay, how come? All right. So this patient has what's called intermediate risk disease. And when you have intermediate risk, the preferred agent is not imatinib. All right. Ponatinib we use in very specific situations. You typically have a very specific mutation, which I did not tell you this patient has. But why not dasatinib? Oh, does anybody want to guess? Say again? COPD, excellent. So bosutinib and dasatinib are both appropriate choices, but for this patient, she has a comorbid condition that makes me anxious about dasatinib. Thank you, sir. Good work. All right. So here is a table that I have created showing you the 5 BCR-ABL tyrosine kinase inhibitors, names, relative potencies, but what is most important on this table is that they all have what we call off-target effects. All right. I don't think you need to memorize which off-target effects it has, but what I want to show you is they have different alternative targets, and that might explain some of the adverse effects and why they're different between the agents. All right, so the landmark study that cemented imatinib as the rock star of the CML world was called imatinib. All right, so way back in the day, imatinib was studied in the IRIS trial that randomized imatinib to what was the standard of care at the time. That was interferon alpha and subcutaneous cytarabine. All right, so yuck, all right? Again, these were jaw-dropping results at the time. We saw complete cytogenetic response, so that's CCYR, at 18 months in 75% of the patients. We had never seen that before, and it was sustained at 5 years, right? Event-free survival was longer. All the things we wanted to see was longer, except overall survival, and the reason for that was they allowed crossover. And just about everybody crossed over out of that interferon arm. You can certainly understand why. But again, this was rocked the world of oncology and specifically CML. There's actually a really great paper in the New England Journal called "Imatinib Changed Everything," all right, which is just a great way of how they designed that drug to target the mutation they knew that these patients had. All right, so if you've heard me give this talk before, here we go. So when we looked at the long-term data from the IRIS trial, we noticed there was this little blip that everybody had a really great response, but at about 2 or 3 years, some of the patients would start to lose that response. All right, so I read once a paper that little blip is called ghost in the machine, right? Like there's something in this machine that is, making things a bit complicated. So my favorite artist of all time, Sting, has an album with his band, The Police, called Ghost in the Machine, and I have a small crush on Sting, as I said, and by that I mean completely inappropriate. I'm a professional groupie, right? So anytime I can talk about him or think about him, I do that. So here, when you think about why patients might lose their response, you think about Sting. All right, why is that? Why would the patients lose their response after 2 or 3 years on therapy? There's 2 reasons. Say again. Non-compliance, excellent. Because how did these patients feel when they started these drugs? They felt fine, and now we gave them all these adverse effects, right? But also resistance, right? That we can develop some resistance, which urged us to look at some other drugs. All right, so very briefly, the next BCR-ABL TKI that we looked at was dasatinib in a study called Decision. So this was dasatinib versus imatinib in the frontline setting. And there's a lot of data here, but the summary is that more patients who got dasatinib got a complete cytogenetic response, which was the endpoint we wanted, and they got there faster. All right, so they got a deeper response, and they achieved it quicker than imatinib, so even outdoing imatinib that fast. However, there's no difference in progression-free survival or overall survival. Next study was of nilotinib, also a second-generation BCR-ABL TKI, in a study called Enestend. So 2 different doses of nilotinib versus imatinib. Both doses of nilotinib, deeper response, and you got there faster, but no difference in overall survival. And repeating myself, the third drug in this class, or second generation BCR-ABL drug, bosutinib, was compared to imatinib in the before trial, and the exact same findings. Deeper response that occurred faster, but no difference in overall survival compared to imatinib. All right, so how would you choose then between them? This is where I tricked some of you. So there are scales that estimate a patient's risk of progression. Okay, there are actually more than one, and I do not expect you as the pharmacist to ever have to calculate that on the exam. You would read according to the ELTS scale or according to the whatever Sokal score, whatever we used, the patient is either low risk of progression, intermediate, or high. Patients who are low risk of progression can receive any of the BCR-ABL tyrosine kinase inhibitors we just mentioned. But patients that are intermediate or high risk disease should receive either dasatinib, nilotinib, or bosutinib as category 1 recommendations. You can use imatinib, but it is not preferred in the patients that are at higher risk of progression. All right, so the patient that I gave you in the case was intermediate risk, so she would be either dasatinib, nilotinib, or bosutinib. Where things get dicey is we've never compared these agents to anything other than imatinib. So there are no trials between dasatinib versus bosutinib or nilotinib versus dasatinib. So here's where we got to get individual patient decisions. So things you would think about. What risk are they? As I mentioned, risk of progression. Looking at the drugs. What are the toxicities, and can my patient tolerate that? Is adherence going to be a concern because they're not all the same dosing schedule? How much does it cost? And I have to give a shout out, you guys, I'm from Pittsburgh, so Pittsburgh's native son, Mark Cuban, you guys know, is doing all his cost plus. one of the drugs he used as an example to promote that product was, or his program was actually imatinib. Right? I'm talking about differences in cost. Whether a patient has comorbid conditions, drug interactions, and sometimes our physicians just like one better than the other. What we should not do in the frontline setting is try to increase the imatinib dose. Okay, you should not try to overcome imatinib's lack of a recommendation in the intermediate or high-risk setting. Although you might get a response faster, it's more difficult to tolerate, and actually more patients will need to come off therapy. So we do not recommend increasing the imatinib dose. All right, so I would think this is a very important slide, and I'm not saying that just because I made it, right? But this slide I use to distinguish between the side effects of the drugs. All right, so imatinib, I would say, has a lot of annoying side effects that patients might have to deal with low-grade problems for a very long time. So none of these are what I would call deal breakers, but they're significant in some patients. So these would be things like nausea, muscle cramps, rash, and eye swelling for some reason, periorbital edema. Dasatinibs, major toxicity, fluid retention, more fluid retention, and a bunch more fluid retention. All right. About a quarter of the patients will need a thoracentesis for a pleural effusion while they're on dasatinib. So nobody likes that, right? So the patient in the case had COPD, so I would avoid a drug that has known pulmonary toxicity in that patient since I have other options. All right. Nilotinib, I gotta be honest with you guys, I'm not a fan. All right, I feel this drug is very dirty. It has a lot of QTc interval prolongation, metabolic syndrome, which means things like pancreatitis and hyperglycemia and lipid disorders. So this is difficult to tolerate. I mean, it occasionally warrants an admission for cardiac effects, so I'm not a fan. All right. Bosutinib, number one toxicity, GI, which is usually self-limiting. But again, if I had a patient with Crohn's disease or IBD or something of that nature, don't pick that one, right? Pick a different one. Ponatinib, oh boy, all right, very toxic. On my initial table where I showed you the off-target toxicities, I actually just wrote numerous because I couldn't cram them all in there. So it has many toxicities that are very serious and requires a REMS program, so I will discuss that in a couple slides. And our newest drug for CML is called asciminib. Hasn't been out for very long and appears to be quite well tolerated, so I didn't bold any of those because we don't know yet. All right, so our patient was started on bosutinib, 400 milligrams a day, and after a year of therapy, she has not achieved the milestone we hoped she would have, that complete cytogenetic response. We have spoken to her, and she is adherent to her therapy, and you've reviewed her med list, and she has no drug interactions. So which of the following is the most appropriate intervention for this patient at this point in her course? Would you increase bosutinib to twice a day? Change her to high-dose imatinib? Order a BCR-ABL1 mutational analysis? Or change to asciminib? All right, I will see how everybody did here. Good, very good. All right, so again, I think there's a lot of moves to be made here, but of the ones that I offered to you, probably the most appropriate is to consider whether the patient has developed a mutation. All right, so you would do that by ordering a mutational analysis test. All right. There would be no benefit to increasing the dose of bosutinib if she's still in chronic phase, all right, which I didn't give you that information, but she would be. Again, high-dose imatinib, usually not a preferred option. And we cannot use asciminib yet. The patient would need to fail 2 agents before we get there. All right, good, very good. All right, so if our patient needs to change therapy because of disease progression, we would want to check to see if the patient has any BCR-ABL mutations in the kinase domain, because certain agents will now be off the table depending on what mutation the patient has developed. Okay. Again, I have this in a table in your handout. I don't think it's a fair question to ask you any one of those 40 mutations that a patient may have developed on an exam. There is one that I will call out to you on another slide. But in practice, I would read the report, like, oh, the patient has developed a V6G7 mutation, and those patients are resistant to bosutinib, so now I need to change it to something else, right? So in practice, we would use that table to kind of guide our therapy. If the patient needed to change therapy because of intolerance, or they had no mutations that you could identify, if you had started on imatinib, you would move to any of the second generation, dasatinib, nilotinib, or bosutinib. If they had started on one of those first-line dasatinib, nilotinib, or bosutinib, you would move to one still within the second generation. You would never back down to imatinib. Does that make sense to everybody? You would never go backwards. All right, what about a patient that actually needs third-line therapy, which is quite unusual, but does occur? There is an agent called omacitaxine mepisuxinate that has an indication for patients with chronic phase CML who are resistant or intolerant to 2 or more TKIs. So that seems like a good idea. This is a completely different drug that has a completely different mechanism of action. It's actually a protein synthesis inhibitor. So as a scientist, that sounds very attractive to me. Never had a patient take me up on it. How come? Does anybody know? Have you ever used it? Anyone? So it's a subcutaneous injection twice a day. All right, so that is a hard sell to patients, especially when we still have oral options or they're aware of oral options. So again, it's there. I've never had a patient do it. All right. We could consider ponatinib in this setting. It's actually indicated for resistance or intolerance to at least 2 prior TKIs. Here's where we have our new agent, asciminib. And for a patient that has gotten to the third-line setting, you would actually think about an allogeneic stem cell transplant. Okay, this was the historical treatment for CML. Now we don't even consider it until the second or third line. But for a patient that is running out of drug options here, this would probably be appropriate to at least consider. All right, so our new drug in the CML space is called asciminib. And I just think that's a fantastic name, you guys. I love to say it, asciminib. So it is a tyrosine kinase inhibitor, but it targets the pocket of the ABL1 region. So although it does fall under the category of BCR-ABL tyrosine kinase inhibitor, it's called a STAMP inhibitor because it specifically targets that pocket. All right, and again, locks the BCR-ABL into an inactive conformation, so we get some activity in patients that may have developed resistance. It was approved several Octobers ago for chronic phase CML who have been previously treated with at least 2 TKIs. In this setting, in the third line or greater setting, not a specific mutation, the dose would be either 40 milligrams twice a day or 80 milligrams once a day. All right, one of those interesting approvals dosage-wise. But the dose here is very low compared to other settings, which I will show you momentarily. All right, the approval of this drug was based on a study called ASSEMBLE, which was 233 patients who were previously treated with 2 or more TKIs. And they actually randomized the patients to either asciminib versus bosutinib with the primary endpoint of the Holy Grail, major molecular response. And look at that, you guys. These heavily pretreated patients, many of them developed a major molecular response, and they held on to it for quite a while, 96 weeks. Right? So this is a brand new agent for us. We do not have long-term data, but it certainly appears that this will be rising in the next couple of years, both because of efficacy, but also because the adverse effects, although I have listed a lot of them, the drug actually appears to be quite tolerable. All right, so again, science is a good thing. Okay, now let's talk about patients that have developed a resistance from a specific mutation. All right. It is very rare for a patient in the frontline setting to already be resistant. All right, so primary resistance is almost unheard of. Patients develop it over time when they've been taking their BCR-ABL drug for quite some time. So that's called secondary resistance, when they've been on a drug and they develop a resistance to it. This is usually because of a point mutation in the ABL domain. And again, there are many, which I don't think are fair, with one exception, and that's called the T315I mutation. All right. This one we call the gatekeeper mutation, because it makes the patient resistant to essentially everything that we use in the first and second line settings. So it confers resistance to imatinib, dasatinib, nilotinib, and bosutinib. So all of those choices now have disappeared. All right. Obviously, if you found a different mutation, you would match it on that table, as I had mentioned, but I do think the T315I mutation is a fair question. So the study of patients with T315I was actually called PACE, and here's where we initially studied ponatinib. Okay. We also could consider omacitaxine, but again, twice a day, subcutaneous injection. Nobody ever takes me up on that. We can use asciminib in this setting, but note that the dose is a lot higher, and we have much less data in this setting. So it's there, but again, we don't have a lot of experience with this clinically. And again, a patient who has developed this mutation will be out of options very shortly. So again, this is where we would fast track the patient to an allogeneic stem cell transplant. So the bad news for ponatinib, we're using this much more frequently back in the day, but it was actually withdrawn from the market in October 2013 because of increased frequency of life-threatening blood clots and narrowing of the vessels in the extremities. So again, whatever off-target effects it has, it definitely has to do with circulation that resulted in fatalities. So this is the preferred treatment right now for that T315I mutation. But the dose we use is much different than what we used in October of 2013. So it was studied at 45 milligrams, and we did that indefinitely. Now, for a patient that had to take it because of that T315I mutation, we would start at 45, and then we would drop them to 15 as soon as possible, as soon as we saw that their response had been achieved. All right, how do we know that a response has been achieved? I have a huge table or section in your handout that we frequently monitor these patients for those hematologic and cytogenetic and major molecular responses. When you do that and which study you use is clearly defined, but again, as the pharmacist, you would not be ordering those tests, you would interpret them, right? So again, you would be looking for the loss of a response, the development of some sort of resistance. You would be acting on those results. I don't believe you would be ordering them. But the thing you would want to keep in mind is the bottom bullet on this slide. If the patient loses their response or never achieved one, you would want to talk about adherence to therapy. You would look at drug interactions. But if all of those things have been ruled out, then you would want to think about a mutational analysis. All right. Thinking now what I would tell a newly diagnosed patient. So the patient in our case was going to receive bosutinib. Which of the following counseling points should be included in your discussion with her? Food does not impact the effectiveness of TKIs. She can miss one dose of her drug per week without a difference in treatment outcomes. TKIs should be taken once daily to maintain serum steady-state concentrations. Or TKIs may be discontinued if MMR is sustained for 2 years. All right, let's see how we did here. Okay, good, very good. So the most appropriate counseling point here is that we might be able to stop the drug if certain milestones have been achieved and if they are sustained for an extended period of time. All right, so I chose my wording here very carefully, you guys. I said they might or may be discontinued, not a guarantee. All right, food does impact the effectiveness of some of the TKIs. We would never give permission for a patient to skip doses, especially a time period, once a week, right? And not all of them are once daily. All right, I already showed you asciminib is not, but other ones also are not. All right, very good. All right, so again, I made this table to help you compare the agents. All right, so looking across in the first row, some of them are daily drugs, some of them are twice a day. For a patient that has a heavy pill burden or struggles with adherence, I would weigh that very seriously. Some of the agents can be taken without regards to meals. Some of them have to be taken in a fasted state. So again, nilotinib, I'm calling you out, nilotinib, twice a day on an empty stomach, that's hard. That is a hard thing to maintain indefinitely. There's going to be some drug interactions. And again, some of them have interactions with common drugs like H2 receptor antagonists and PPIs that I would need to counsel them about. All right, so again, CML is a chronic disease, and some of the patients will be taking whatever we choose for 25 years or more. The patients on the initial IRIS trial are now more than 25 years out on their therapy. But now this has become a chronic condition, just like all other chronic conditions in this country. So a key point for pharmacists here is that adherence is one of the number one factors for these patients to relapse or lose their response. And this was actually demonstrated in a trial called Adagio, which was done in patients that received imatinib. But I am extremely comfortable extrapolating that data to all of the drugs in this class, right? So again, what a great role for pharmacists to check in that the patient is still being adherent, especially if there's an issue of a side effect we could manage or if the finances are mandating that. Okay. All right, so again, as I mentioned, CML has truly become a chronic disease. There's data to suggest that patients with CML now have the same life expectancy as a patient without CML, which is amazing. So we need to think very carefully about adverse effects, quality of life, financial concerns for a patient who's going to take this drug for the next 20 years. And for our younger patients, what do they want to do about family planning? So is there an opportunity to get the patients off of these therapies, even if it's for a short period of time, for family planning purposes or what have you? And the answer is we might be able to do that. Okay, we might. Several studies, again, which are detailed in your handout, but they're called things like the STOP trial or the Twister trial, have investigated discontinuing the TKI in very specific situations. So patients that have achieved the Holy Grail, major molecular response, or what we call deep molecular response, and sustained it. All right, and we're not calling these patients cured, we're calling this treatment-free remission, or TFR. All right, so I have summarized all the studies in your handout, but the take-home point is all of those studies had very specific eligibility criteria, and the patients had to agree to monthly monitoring for at least a certain period of time. So again, some of our patients just don't want to come to the clinic every month once they've kind of gone on autopilot. Does that make sense? So the patient will get off therapy but actually require more lab monitoring. That's the trade-off. All right. The summaries of the studies. Slightly less than half of the patients are able to stop therapy. All right. Of the patients who are not able to stop therapy, if we get them back on their original drug very quickly, they'll go back into a remission. All right, so again, about half of them can come off. The ones who can't, you need to restart that same agent as soon as possible, which again means the patient has to be very compliant with lab visits and follow-up to do that. Okay. We're also observing what is called treatment withdrawal syndrome. So I do not have a good scientific explanation for this, but about a third of the patients complain of very serious muscle aches, like a flu-like syndrome almost. I don't know why that happens, and I certainly haven't read why that happens. Some patients we can manage with over-the-counter analgesics, but some studies now are looking at discontinuing the TKI slowly to avoid that treatment withdrawal syndrome. So the NCCN guidelines would say that you can consider stopping their drug outside of a clinical trial, but only if the patients meet all of the criteria on this slide. Okay, so not or, and all the criteria on this slide. They have to have a stable molecular response for at least 2 years. They have to have access to frequent and reliable monitoring, and you have to be confident that they will actually do it. And the guidelines clearly say the patient needs to consent to discontinuing their therapy after a thorough discussion of the risks and benefits. So good record keeping here that the patient agrees and understands the risks and agrees to the increased monitoring. Okay, great job, everybody. So in the last couple slides here, we will discuss what you do for the very rare patient that presents in the advanced phases in either accelerated or blast crisis, or a patient who progresses into that because of non-adherence or resistance mutations. All right, so as I said at the very beginning, your goal is to return these patients to the chronic phase, like you just want to beat their disease back down into where it was before. If they were previously treated with imatinib, you could use one of the second generation BCR-ABL TKIs, but the doses are higher now. If they were previously treated with a second generation TKI, you would switch to one of the ones in that same class. You could very carefully initiate ponatinib. Again, you could consider omacitaxine, but this is where you would again be fast tracking that patient to an allogeneic stem cell transplant. For the very rare patient that makes it into blast crisis, again, you need to get them back into chronic phase, but that is not easy to do. We only manage to do that about 50% of the time. All right, so you might think that if you have CML and it progresses into an acute leukemia, it's going to be AML. And that's actually not true. All right, it's about a 50-50 split, or actually a little bit more in favor of ALL, as you heard from Dr. Parasanati. Some of those patients are Philadelphia chromosome positive. So you would first need to determine what type of acute leukemia does the patient have, and then you would treat whatever that type is appropriately, as you heard earlier today. You would very likely add on a tyrosine kinase inhibitor if your patient was Philadelphia chromosome positive ALL. And again, these patients need an allogeneic transplant. That is their only hope at long-term survival, so you would certainly make that happen as quickly as possible. Okay, so we have done it, everybody. Nice work. Congratulations.